collapsed lung and a pneumothorax. Let's take a look at this. Here's an example of a radiograph of someone with a pneumothorax caused by bullous emphysema. Okay, you can see over here we've got a normal left lung. Over here on the right, we've got some problems. Let's take a look at this. Okay, you can see the lucency of the trachea. You can see the hemidiaphragms here, and of course the cardiac silhouette. There's the pulmonary artery right there. You can see it really nicely. And there's the aorta right there. Take a look at the left lung field. Left lung field, you see a lot of vascular markings in the lung field. That tells you that there's lung there. Lung vascular markings show up as these nice fine lines that radiate outward. When you see those vascular markings, you know there's lung there. However, take a look at the right side. You look at the lung field on the right side. Oh, I see something over here, but what about over here? Do you see any vascular markings over there? None. So there's no lung there. Well, where is the lung? Well, it's actually over here. You can see the outline of the lung right here. It looks like it's pulled away from the thoracic wall, and now it's collapsed on this side. It looks like it's collapsing into something rather small. Instead of the lung being fully expanded in the thoracic cavity, now you've got an absence of lung here. Instead, you've got air. That's the pneumothorax. And it occurred because bullae up here ruptured, allowing the pressure to equalize in the thoracic cavity. And this equalization of pressure allowed this lung to recoil, and now it's collapsed. Now you've got a pneumothorax. Okay, so this is a common complication of bullous emphysema. Any questions on that? Yes.
That causes that. That's the disease, the pathology, thorax.
Yes, this is what causes pneumothorax. So if you take a look at these, this is made of visceral pleura, and it's the only thing holding the atmospheric air into the lung. Okay. Out here in the pleural cavity, we're supposed to have subatmospheric pressure. If a hole develops here, the pressures equalize. And since the subatmospheric pressure no longer exists in the thoracic cavity, it's now equally it's equal to the atmospheric pressure. This lung is going to recoil and collapse. There's nothing expanding.
So the FEV1, the air goes in, but doesn't come out.
The air goes in, very difficult time getting it out, and that causes the hyperinflation.
So FEV1 means the air doesn't come out.
FEV1 just refers to the volume that you're displacing in the first second when you forcefully expire. Yeah, FEV1, forced expiration volume 1 second.
And the FVC is low too.
FVC is the forced vital capacity. So deep breath in, exhale as much as possible, no time limit. The air that you displace, that's called the FVC.
So both of them are going to be down.
Only in obstructive diseases will the FEV1 be declined. The FVC should be normal in an obstructive disease. It's reduced in a restricted lung disease.
FEV0, which one is that?
Okay, so we subclassify emphysema as a chronic obstructive disease. Therefore, the FEV1 would be reduced. The FVC would be normal. That's what classifies it as an obstructive lung disease. We base the subclassification based on the spirometric changes. I think there was a question over here, back here.
Back to the bullets, like eruption as a result of bullets when the lung collapses. What do you call that?
A pneumothorax. That's a pneumothorax, right?
I was going to say the FBC, it stays normal because it can still get past the obstruction. It just take longer to get out.
Yes, because it's what we're really battling with is an increase in resistance to airflow during the expiration phase. So if you just took your time to exhale, you should have the same forced vital capacity. Yes.
So with like chronic with COPD, it causes what barrel chested.
Yes, we're gonna get to that. The remodeling of the chest.
Oh, I was about to say, like, once it collapses, would it go back to normal, the chest, or stay very?
No, the chest changes because of remodeling. You know, the constant mechanical pressure placed on the chest, and so the chest kind of bulges outward. If you've ever seen people with really bad emphysema, the abdomen looks like it's a normal diameter, but the chest seems like it kind of bulges outward. And we're going to define what barrel chested means in a minute. Okay. All right. Let's take anything else. Let's take a look at the cause of this problem. The cause of this problem is increase in elastase activity. This is the enzyme that degrades the structural integrity of the airway. Again, normally, lots of structural proteins in the airways, making the airways very sturdy. They can withstand a lot of the different pressures in the exhalation phase, such that they do not collapse. As a result, easy to inhale, easy to exhale. However, when you increase the enzyme elastase activity, you get a degradation of the structural proteins, making those airways very flimsy. And that's what caused the airway to collapse, trapping air in the lung, causing hyperinflation of the lungs. That causes the alveoli to rupture and ultimately the bullae to form. Now, there are two mechanisms whereby elastase activity increases in the case of a cigarette smoker. Most of the cases of emphysema is caused by cigarette smoking. There are other causes, but most of the cases caused by cigarette smoking. Cigarette smoke increases elastase activity by two mechanisms. First mechanism, it increases the elastase enzyme production from alveolar macrophages and neutrophils. So now the white blood cells are making more of this elastase activity, more of this elastase enzyme. Okay. Secondly, cigarette smoking also decreases the activity of an anti-elastase, something that normally inhibits the elastase enzyme activity. So this protein that's produced that normally opposes elastase is called alpha-1 antitrypsin. Alpha-1 antitrypsin normally inhibits elastase. Well, cigarette smoking decreases the activity of alpha-1 antitrypsin. It's an inhibitor. When you decrease the activity of an inhibitor, you disinhibit the elastase enzyme. And so the activity of the enzyme increases. So now you have two mechanisms whereby the activity of the enzyme increases. Number one, you have more of it. Number two, you're disinhibiting it. And so as a result, all of this culminates in increased elastase activity. The elastase activity does a lot of damage to elastin fibers and collagen. This causes the airways to be very, very flimsy. The airways will collapse during the exhalation phase. And of course, that results in emphysema.
Do you only have more of it because of the disinhibition, or are you also upregulating the transcription of elastase?
You have more of the elastase enzyme itself.
Okay.
It's made by neutrophils and macrophages. So you have more of the enzyme and you're disinhibiting. So those are two mechanisms whereby elastase activity increases.
Why neutrophils are there? What are they doing there? What are they?
They're normally residents of the alveolar macrophages. It's they should be there. They're cleaning up debris that we inhale. Anything else? Yes.
Does destroying the airways, does that affect the inspiration too, or like how come it's only that's expiratory?
Does that affect the expiration?
Inspiration.
Generally, inspiration is fairly normal because when the lungs expand, the lungs tether the airways open, as they kind of are pulled outward by the diaphragm and by the intercostal muscles. They in turn pull on the airways. And so the airways that collapse during exhalation become patent during inspiration. So people can inspire, but they really can't expire. Period. Yes.
Is the visceral pleura that makes up a bullae capable of remodeling under chronic pressure, kind of like the pericardial sac?
Just like the pericardial sac, and that's how those bullae they form.
Okay. And it's a spontaneous rupture. You don't really know when it's.
Yes, generally there's no forewarning. It's more likely to happen in someone who's tall and generally thin. but there's just no warning. Just give. The way we would correct the problem is we would purposefully go in and irritate the parietal pleura. They irritate the visceral pleura, so there's some inflammation. We put the two together so they fuse. And as a result, the lung can't collapse. There's too much scarring that keeps them expanded. It causes some chest discomfort because obviously they're supposed to slide. But if you have one lung collapse, you're okay. You can rely on the other lung. If you have two lungs collapsing at the same time, yeah, you're kind of out of luck there. So that's what we worry about. It's justifiable. Anything else? Okay, so a couple of things happen when you have emphysema. Of course, you lose a lot of alveoli. You lose lung parenchyma. We said that reduces the diffusion capacity of the lung. And it also causes increase in resistance to blood flow from the right side of the heart to the left side of the heart, ultimately causing chronic core pulmonality. Now, because of the hyperinflation, there are a lot of mechanical remodeling of the chest, the pleura, the lungs. Because of the hyperinflation of the lungs, very often the chest starts to bulge outward, such that the anterior posterior diameter exceeds the transverse diameter. Now, normally the transverse diameter of the chest is supposed to exceed the AP diameter of the chest. But because of this remodeling, because the chest bulges outward, the AP diameter exceeds the transverse diameter. And as a result, people take on a chest morphology that looks like a barrel. And that's because they're hyperinflated. Let's take a look at all of this. Take a look at the chest radiograph, comparing a chest radiograph with the normal limits to a woman with emphysema. Let's take a look at the normal chest radiograph first. A couple of things to notice. Notice the morphology of the chest. You see the lucency of the lung kind of creates a very gradual inverted V. See how that? That's normal morphology. Okay. Take a look at the diaphragms. Look at the curvature of the diaphragms. See how nice and concave they are? Nice curvature of the diaphragms. That's normal too. Take a look at the cardiac silhouette. Look at the cardiothoracic ratio. It's less than 0.5. Okay, it's not too big, not too small. Everything looks good here. When you examine the radiographic appearance of someone with chest appearance of someone with emphysema, you'll note there are characteristic features of hyperinflation. First, take a look at the morphology of the chest. The morphology of the chest, what does that remind you of? A barrel. A barrel. Okay. Barrel chested. This person's barrel chested. Take a look at the diaphragms. The tops of the diaphragms. You see how flat they are? Flattening of the diaphragms. Okay, that's caused by hyperinflation of the lungs. Normally, when the diaphragm pulls down, normally the diaphragm pulls down on the lungs, and it causes the lungs to expand. And as a result of pulling down the lungs, you get a vacuum here that causes the domes of the diaphragms to pucker upward like this, and you get that nice curvature. Over here, the lungs are hyperinflated. The diaphragm isn't pulling down on the lungs over here. The lungs are pushing down on the diaphragm. You're getting the flattening of the diaphragm domes. So this is a sign of hyperinflation. So you got the morphology, you got the flattening of the diaphragm, both consistent with hyperinflation. There's another clue that these lungs are hyperinflated. Take a look at the cardiothoracic ratio. What do you think? Very small. Right? Look how small that cardiac silhouette looks. And that's because the lungs are hyperinflated and they're compressing the heart in this direction. And so the frontal profile of the cardiac silhouette was very thin. Okay? Again, another sign of hyperinflation. So you got a lot of different clues here that these lungs are hyperinflated. Take a look at a lateral view. Okay, let's first take a look at lateral view of a normal chest. Again, this is a left lateral view. Sternum, vertebral column, you can just make out. There's the cardiac silhouette. You look carefully, you can see the curvature of the right hemidiaphragm there. That's the right hemidiaphragm. And you can just make out the curvature of the left hemidiaphragm here. Everything looks really good, nice curvature. Okay. Of the two diaphragms. Okay, taking a look at the AP diameter, everything looks like it's in proportion. Okay. If that's normal, take a look at emphysema. Okay, look at the diaphragms. See how flat they are. Lungs are pushing down on those diaphragms. Normally, the diaphragms are supposed to pull down on the lungs, but these lungs are pushing down on those diaphragms. Okay, because they're so hyperinflated. And look at the dysmorphism of the chest. And look how wide that AP diameter is. That's the definition of barrel chested. When the AP diameter exceeds the transverse diameter, that is the point where the person becomes barrel chested. That's the definition of barrel chested. AP diameter exceeds transverse diameter. Okay. And again, here's just an emphasis of the definition of barrel chestedness. If we take a look at the cross section through a normal chest, usually the transverse diameter the average transverse diameter will exceed the AP diameter. But the person who's barrel chested, the AP diameter exceeds the transverse diameter. That's the definition of barrel chestedness. And again, that occurs because the chest remodels over time. You have these lungs that are expanded, they're pushing up against the chest. Eventually, the chest remodels and takes on this barrel-chested morphology. Even if the lungs collapse, the barrel-chestedness isn't going to resolve. I mean, the chest is remodeled at that point. Okay. Any questions on that? All right, a few other things we need to know about emphysema. I said that emphysema is very frequently caused by cigarette smoke. Well, there's another disease that's very commonly caused by cigarette smoke, chronic bronchitis. Chronic bronchitis. And very often, because of the common etiology of both diseases, when a person has emphysema, they often have chronic bronchitis at the same time. Now, when we're looking at patients with emphysema, there are kind of two extreme patients we see. One end of the spectrum, we have a person with emphysema that doesn't have any chronic bronchitis, okay, or very mild chronic bronchitis. On the other end of the spectrum, we have someone with emphysema that has severe chronic bronchitis. Now, we're going to talk about chronic bronchitis next, but it's characterized by the production of a lot of mucus that's produced in the airways. And very often people with chronic bronchitis are coughing up a lot of sputum. Okay? Let's take a look at these two different extreme patients. Okay? Here are the two extreme patients I talked about, both ends of the spectrum. Because cigarette smoking causes both diseases, we often see the two diseases coexisting in one patient. Okay, at one end of the spectrum, we have someone with just pure emphysema. These people with just pure emphysema are called pink puffers. Pink puffers. The other end of the spectrum, we have people with both emphysema as well as chronic bronchitis. These people are called blue bloaters. Blue bloaters. Let's take a look at the pink puffer. This guy just has emphysema. And depicted here is the typical body habitus of someone with chronic emphysema, just emphysema, and no chronic bronchitis. Okay, typically they're kind of thin. They're well oxygenated, so they're pink. And typically they're kind of leaning forward, and they've got their mouth kind of closed. They're breathing kind of a funny way. They're inhaling like this through their mouth, and when they exhale, they close their mouth a little bit, and they exhale like this. Okay. These are called pink puffers. Again, they're pink because they still have good gas exchange. It keeps them oxygenated. They're usually breathing through their mouth like this. When they breathe through their mouth, they don't like to eat because then they can't breathe. And so typically they're very thin. They do spend a lot of energy trying to breathe. So the pink puffers, they're well oxygenated and they're thin because they're not eating very much. Okay. Other end of the spectrum, we have the blue bloater. Okay, blue bloater has chronic bronchitis, is producing a lot of mucus in their lungs. They're coughing up a lot of sputum, and they have all that in addition to the emphysema. These people typically don't have good gas exchange. And as a result, they're very often cyanotic. You see kind of blue around the fingernails. blue around the lips. Also, they're very lethargic and they're not well oxygenated. They're retaining CO2 because of all the mucus in the way on top of their emphysema. And so they're kind of lethargic, don't do very much, and they tend to be very heavy set and cyanotic. So we call those blue bloaters. Okay. The only difference between these patients, this guy has pure emphysema, this guy has emphysema plus chronic bronchitis. And those are the two extreme forms of patient with emphysema that you see in clinic. Usually most patients are, of course, somewhere in between, but those are the two extreme forms of patient. Okay, any questions on that? Blue bloaters, pink puffers.
Would they typically, with both ends of the spectrum, typically be wearing some kind of oxygen tank assistance?
Yeah, we can give some additional oxygen nasal cannula. That enriches, doesn't enrich the oxygen by very much. It goes from 21%, I believe, up to 25, 26%. We have to be very careful. In fact, that's a good question. We have to be very careful giving these people pure oxygen. Most of the time, when we breathe, we have that quote unquote air hunger, holding our breath, we have to breathe. It's not because our oxygen levels are going down, it's because our CO2 levels are going up. We actually want to breathe. Most of the drive for respiration is because CO2 levels are building up. These people with emphysema are chronically retaining a lot of CO2, and so they're kind of desensitized to that high level of carbon dioxide. These people breathe primarily because they're deficient in oxygen, not because they're high in carbon dioxide. It's been desensitized. As a result, they're breathing purely to get oxygen. They don't even care about CO2. They're just purely breathing to get oxygen. If you put these people on pure oxygen, they get all the oxygen they need, their blood's saturated with oxygen, they actually stop breathing. And so we have to be careful with how much oxygen we give them. We just generally give nasal cannula and that's it. Yes?
What did you mention when you said that the lupus is on the way of the CO2 coming on?
With what?
You said they retain CO2 because lupus is in the way?
Both of these patients retain CO2 because their diffusion capacity is limited. Remember, the alveoli are destroyed. That means that when you lose an alveolus, you lose the surface area through which diffusion occurs. So every time an alveolus is destroyed, you lose that diffusion capacity for both CO2 and oxygen. Over time, they start retaining CO2. They become, there's a fancy word for that, called hypercapnia. Hypercapnia. They retain CO2. Hypercapnia. And that desensitizes their drive to breathe because of high CO2.
So the FB1 is down because the alveolus dead.
The
The FEV1 is down.
okay, that's just measuring the mechanical efficiency of the lungs and respiratory system. It doesn't tell you anything about the gases that they're retaining or anything. The fact that you've lost diffusion capacity, you've lost cross-sectional area, that's what causes the inefficiency of gas exchange. Any other questions? Okay. Let's talk about the workout. Okay, so usually the definitive diagnosis is based on chest radiograph and recognizing the morphology of hyperinflation and some changes in the lungs. Usually when you start to see changes in the lung and the chest morphology, it's already too late. The emphysema is already actually in its advanced stages. Early on, you can't really see any radiographic changes. You, of course, can detect some changes in spirometry early. The FEV1 will be decreased. However, by the time you see corresponding changes in the radiograph, you've got significantly advanced emphysema. Okay, we talked about some of the bullae causing pneumothorax. Microscopically, you would see a lot of alveolar destruction. And the alveoli just pop because of the high pressures in the alveoli. We would have a loss of elastic tissue in the airways. That's what causes them to be flimsy. That's caused by elastase activity. And based on the etiology, they probably would have some degree of bronchitis, chronic bronchitis. That's because of the cigarette smoking that gave them the emphysema in the first place. Spirometry would support the presence of a chronic obstructive pulmonary disease. Now, I mentioned again, most common cause for this, cigarette smoking. There are some other causes. There are some genetic diseases. The one genetic disease that can cause emphysema is a defect in the gene that codes for alpha-1 antitrypsin. That's the inhibitor of elastase. If you have a defect in that gene, you don't make alpha-1 antitrypsin, you don't inhibit elastase. Elastase activity is disinhibited. It will also cause emphysema, but the emphysema will occur at a much younger age. Typically, people who develop emphysema as a result of cigarette smoking, what would you guess, what age? Good, yeah, it's about 50s, 60s. Okay, and if you had to guess, a genetic disease causing emphysema, like an alpha-1 antitrypsin deficiency, what age?
20.
20s, yeah, 20s, early 30s, exactly. You have someone presenting with emphysema, you know, if they're 29, either they're smoking, you know, pack after pack, never giving it a rest, or they've got some sort of genetic problem. And if you have someone with an alpha-1 antitrypsin deficiency and they're smoking on top of it, it can even be earlier. Emphysema can even present earlier. So yes, genetic diseases usually cause earlier presentation. Anything else? All right, then let's just introduce you to chronic bronchitis. Okay, another chronic obstructive pulmonary disease, chronic bronchitis. Again, primary etiology, cigarette smoking. There are other causes. The airways can become chronically inflamed by cigarette smoke. They can become chronically inflamed by industrial pollutants. One of the big ones being sulfur dioxide. Sulfur dioxide is kind of a byproduct of manufacturing. When someone inhales sulfur dioxide, it turns into an acid and irritates the lungs, causing a chronic bronchitis. Okay. Now, there is a specific definition for chronic bronchitis. It's in your notes. Chronic bronchitis is defined as a persistent cough for 3 months in 2 consecutive years. So in order to diagnose chronic bronchitis, you have to have 3 months in 2 consecutive years of chronic coughing. Usually with the chronic coughing, a lot of sputum production is developed as a result of all the inflammation in the airways. So people are coughing up a lot of mucus at the same time. Sometimes the irritation is seasonable because it's caused by something that's irritating the airways by season. But whatever be the case, specific denotation of chronic bronchitis, chronic cough, 3 months in 2 consecutive years. Again, it's very common in cigarette smokers, areas where you find a lot of air pollution. The inflammation causes the airways to become very thick, and a lot of the mucus that they produce as a result of the inflammation further reduces the diameter of the airways that are patent. And as a result, you get these very kind of thin luminal diameters in the airways, and it makes it difficult to exchange air. Let's take a look at an example of this. Here's an example of depictions of airways, normal patients and someone with chronic bronchitis. Again, you have normal over here, nice and patent lumen, very sturdy wall, nice and sturdy, good structural proteins in that wall. Over here, you got chronic bronchitis. The wall is thicker. The wall is thicker at the expense of the luminal diameter, so that decreases luminal diameter. In addition, you got a lot of mucus production because of the inflammation, and that further reduces the available luminal diameter. A lot of mucus is produced as a result of chronic inflammation. If the person is not coughing up a lot of mucus, they don't have chronic bronchitis. the mucus production is one of the defining features of chronic bronchitis. Person that coughs, they're coughing up this mucus because of a lot of inflammation. Now, we talked about another condition that's characterized by chronic inflammation of the airways. We talked about asthma, right? Okay. How do you think chronic bronchitis is different from asthma related to the inflammatory cell infiltrate that you see in the walls? What's that? You see mononuclear cells, you see neutrophils. I guess let me ask it this way. What cell don't you see in chronic bronchitis that you do see in asthma? Eosinophil, that's right. Chronic inflammation, almost identical to that of asthma, except you don't see the eosinophil. The eosinophil is absent in chronic bronchitis. It's present in asthma, but absent in chronic bronchitis. That's a big difference between the two. Chronic bronchitis, of course, it is an inflammatory type of disease caused by irritation. You see neutrophils, mononuclear cells, all kinds of inflammatory cells, but what you don't see is the eosinophil in chronic bronchitis. Okay, let's take a quick look at this inflammation. Here's a section through the airway of someone with bronchitis. You can see the lumen over here. Okay, and you can see the airway wall over here. Okay, and take a look at the lumen. Look what's in the lumen. A lot of inflammatory cells. Okay, this is often in the mucus that they're coughing up. Mucopurulent plug in the airways of people with this bronchitis. The inflammation damages the respiratory epithelium. Take a look at the respiratory epithelium. It's a pseudostratified ciliated epithelium there. Look what it's doing to the epithelium up here. It's ulcerating the epithelium. It's causing the epithelium to erode away. It's doing a lot of damage to the airways. All of this chronic inflammation is going to cause some structural changes to the airway, making the airway very thick. This very delicate pseudostratified ciliated epithelium actually undergoes metaplastic change. It changes into a stratified squamous epithelium. It's very delicate, this respiratory epithelium. All of this inflammation damages it and turns it into a stratified squamous epithelium. Okay, so we see kind of squamous metaplasia in the airways of people with bronchitis. Take a look at the wall here. The wall's infiltrated with a lot of inflammatory cells. I see all kinds of inflammatory cells except the eosinophil. I don't see it here. Okay, it's conspicuously absent in chronic bronchitis. A lot of hyperemia here. That's all blood vessels. In short, you've got a wall here that's infiltrated with a lot of inflammatory cells, going to make it thicker. You have architectural changes due to the chronicity of the disease. Plus, you have a lot of mucus in the lumen. Okay, so these people are going to have difficulty exchanging air because the airways are very narrow. Plus, because the airways are irritated, they're going to be coughing a lot. Plus, all this pus, all this mucus, excuse me, they're going to be coughing that up. So some of the defining features of chronic bronchitis, you have this cough, and this cough is productive of a lot of mucus. If someone is not coughing up a lot of mucus, they don't have chronic bronchitis. It's a defining feature of chronic bronchitis. Okay, why don't we take a break here, then we're going to talk about the changes of the architecture in the wall as a result of the chronicity of the inflammation.